So this is our weekly webinar series called Telehealth Failures and Secrets of Success. And this is following a very successful conference in December. So today I'm super excited. We have Glenn, the CEO and founder of New Physica, and I would consider him my most personal friend and mentor and someone I actually look up to. He's just, of all the people in the telehealth, I consider him one of the true thought leaders. And I think today I'm pretty excited he will share with us his insight on telehealth from Walmart to Texas prisons, and of course the implication for larger healthcare discussion. And so today the format is Dr. Hammack will give a roughly about 10-minute presentation, and I'll be just chatting with him for about 20 minutes, and we're going to open the floor for about 15 minutes for questions from the audience. I guess maybe we can start with Glenn. Maybe you could give a quick intro of yourself, and then maybe we'd love to hear your thoughts.
Great, Milton. Thanks for that very thoughtful and flattering introduction. I really appreciate it. For the group that's watching, again, the VC group and Milton has really been an amazing addition to the space, and we have a lot of good alignments in the way we think, so I hope that this will be a helpful conversation. So, not to go into it, but a little bit about me. For those of you that don't know me, I like to say I've been making mistakes in telemedicine for 20 years. I started life as an eye doctor, of all things, at Henry Ford Hospital. I'm the world's worst testament to career planning. 5 years at Henry Ford Hospital, and then 10 years at University of Alabama, running their eye clinics for the optometry and ophthalmology divisions. I did some graduate work in health informatics there, and to finish that postgraduate degree, I ended up doing an internship at Massachusetts General Hospital, where by absolute dumb luck I got assigned to the telemedicine group there under Joe Vadar. This was about 1998. It was a wonderful time to learn and see what at that time was starting up. There's a lot of concepts in telehealth and telemedicine. Very innovative group up there, continues to be a leader in the area with their connected health symposium and other areas. Then I was a tenured faculty member, and I had built the house I thought I was going to retire into in Birmingham, Alabama, and I started getting calls from the Texas University of Texas Medical Branch. And after a lot of discussion and conversation about moving my 14-year-old daughter, we ended up moving to Houston. I was just going to do it for a 2-year period, and that was 14 years ago. So it goes to show you how things change. So anyway, enough about me. Let's dive in a little bit. So again, I had the unique opportunity to get started in telemedicine at Mass General, but then was asked to take over a very real business case inside of all places, the Texas prison system, which is operated out of the University of Texas Medical Branch, which is not in Houston. It's down in Galveston, Texas. It's the oldest medical school west of the Mississippi. And so in 1995, this is what was called telemedicine. You were using ISDN circuits. You were linking, basically ISDN connected video conferencing systems at both locations. You had a camera for near, camera for far. A lot of things are recognizable because a lot of the basic modalities haven't changed as the technology has changed. The device in the upper left corner was called a portable unit, of all things. It was about as big as a full-size refrigerator. And that's what was in a small number of Texas prisons when I took over the program. While we were there, through some investments, we at that time decided to do the radical thing of using IP connectivity for video conferencing. We built a statewide IP network that one didn't really exist before. Everything was being run on mainframes. And we built an environment to really make telemedicine a preferred modality for physicians. So what you see in these photographs here are our studios. The upper right one that looks like the bridge of a starship was for specialty services. You had the video conferencing presence on the wall. You had screens in front of the provider for electronic medical records and other types of internet access tools. And then in front of them, these screens actually in the desk were for utilization review case management system. They really, in real time, would extract things from the medical record and give advisement and when someone was on protocol or off protocol right there to the physician during the visit. The lower left one, the beautifully paneled wood one, was for primary care docs. And again, video conferencing presence on the wall. You had EMR screens and utilization review case management screens in front of the provider. And these are still down there in Galveston. They're still used in the Texas Telemedicine program. What we were putting next to the patient was a form of a cart in the lower right. You had an otoscope, you had a laryngoscope, you had a live stethoscope system along with the video, and this was kind of the standard setup that we were putting in 2000. This is a younger version of me showing what I know by looking into the ear and seeing a patient's bowel with the colonoscopy image on the screen, but it just goes to show that time spares the ravages to no one. And I was thinner and had darker hair, but this is where we were. It was a good time. We started the program with orthopedics, and it grew from there. By 2006, so this would be 5 years into the program, this is where we were in terms of correctional encounter volumes. We were doing around 37,000 visits a year. As you can see the breakdown, we were doing primary care to a certain level. In the way that this program is running today, it's at about 160,000 visits a year. About a third is specialty care, about a third is primary care, and about a third is behavioral health. So it's a really good, robust program that's continuing under the leadership of those folks today. A lot of great leaders are continuing the tradition that we started. So over time, we had some recognition. The Gartner group did a study on us that you can see the number there. We got some recognition from Gartner for the way we were implementing a combined electronic medical record and telemedicine strategy. And it was great, and to see it still being recognized. So 2016, the Pew Charitable Trust did a report on the Texas Prison System's telemedicine program, and the leadership there that's quoted were the team that we work with in building it. And so it's, it's great to see that it's continuing to go. So it is still the largest ongoing telehealth network in the U.S., and it has a significant number of visits for site-to-site telemedicine. It's really an industry leader. So it's kind of is quietly in the background, really doing what a lot of folks wish they could do in terms of building programs. Another program that I wanted to highlight was some work that we did with Walmart's in the 2008 timeframe. We had just started the company out of the university. What had happened in the university, we had our successes inside the prison system. We had built some intellectual property and process and method and technology that we licensed out. We had actually 3 patents. We started doing work in an incubator called the Electronic Health Network in 2004. And by 2007, we were doing work outside the state of Texas. And so we, with this university support, we spun New Physician out of the university at that time. And we've been going strong ever since. But in the early days, one of the more interesting programs that we did was in 2008, we were approached by a nurse practitioner retail health group that was having some compensation challenges by trying to find nurse practitioners. And they had a contract for 6 locations around Houston inside Walmart's for retail space. And so we undertook this project. It was very interesting and innovative for its time. We brought in our EMR. It was financially very interesting because it was pure cash on the barrelhead. We didn't take insurance. It was a cash check or charge. We didn't use any grants. It was a pure economic endeavor of the company. And so it was really, I cherish it because it offered telemedicine to the public for a cash on the barrelhead, unsteered, unmodified, not cost-shared basis, and gave us a lot of confidence into 2 things. Gave us a lot of confidence in the economic viability of these kind of programs, and gave us a lot of confidence into the patient acceptance of this modality. This map has the blue markers where the clinics were around Greater Houston. If you know anything about Houston, you know that the lower right corner is kind of industrial. The upper left corner is a little more residential. The far west area is actually the up-and-coming area called Katy. This is what they looked like on the inside. The trade name for it was Walk-In Telemedicine Healthcare, or With Care, and it was staffed by a medical assistant at the reception desk, and we use a model of paramedics next to the patient. That helps us with a lot of the emerging rules at that time. For telemedicine, we had to have a state-registered health professional next to the patient for all patient care. In the rooms, we put our cart systems. We connected them by standard business class DSL, using Polycom equipment as the core, and then using our standard suite of otoscopes, laryngoscopes, and live stethoscope systems, and patients were seen. It was a great program. This paramedic, even though he looks young enough to be a high school student, was actually a very skilled gentleman. His name was Doug. He's still with us, and if I ever have to be intubated on a freeway in the middle of the night, I would want him to do it. He's a very skilled young man. This is what the clinics looked like in the environment when it was running. This was one of the grand opening days. It was all walk-in service. We really didn't even bother to take appointments because it was all walk-in retail access. And again, other than that being a darn good price on Doritos there, we always knew when our doctors were connected to the Walmarts because we could hear the beeping of the cash registers through the video system. So it gave us a curiosity in terms of knowing where the doctors were seeing patients at any given time. What kind of patients did we see? We ran this program for about 2 years, and I'll talk in depth a little bit about why we stopped doing it. But the age range that we accepted was anything over age 2 with no upper age limit, and this is what we saw was pretty consistent each month. The average age was around 30, 35. We saw patients as old as 90, in some cases over 100. We saw patients as young as age 2. This is the kind of problems we would see. This is a report from a snapshot from a given month. A lot of convenience care, general physicals, upper respiratory tract infections, pharyngitis, sinusitis, bronchitis, and then a smattering of things. And I think most folks would say that for convenience care, this is a pretty standard profile. Operationally, this was our monthly volume per site per day, and our revenue per patient per day. We were $59 cash on the barrelhead with supplemental fees for lab testing, and we were achieving some pretty decent numbers in terms of our revenues. So what happened to it over time? Well, if those of you that were in the space at that time will remember, Walmart went from just renting space to folks at the back of the store for retail health care, putting us there between the nail salon and the bank. And then they started the operation called the Clinics at Walmart, which was a franchising opportunity. And when they came out with that, they offered it to us. We took a look at the requirements of that program at that time, which was a franchising fee and having to use their designated medical record system, having to buy all consumables through Sam's Club. We looked at the books, we looked at what we knew the operation could do, and we just didn't see the fit. We just stepped away from it at the end of, I think by the middle of 2009, and things moved on from there. But again, we learned a lot. What did we learn? Again, we learned that the public really did accept this as a care modality. When we started it, we thought we would have to do a lot of patient instruction about what to expect, and now the doctor's really not going to be in the room, and so we've got to make sure everybody understands. And then what happened was the patients got it right away. We actually kind of even did like an informed consent video that we had ready to go. We put in DVD players with monitors to play the informed consent video for every patient. And after about the first 2 or 3 months, we took them out because patients got it. We didn't have anybody who said, wait a minute, the doctor's really not here. Patients got it, so that was very good. The other thing was, while we got a lot of interest in this program, and to a certain extent a lot of press from folks even like Elizabeth Cohen at CNN, who interviewed me on Christmas Day in 2009 and put it on the air, they were expecting this clinic to be a poor person's clinic. They expected that this was a technology that would help the great unwashed of America. And again, if you look at the revenue per patient and you look at the kind of payer mix that we had people paying for us with their American Express Black Centurion cards, and that was a lesson too, that it was not folks coming to us from hard-scrabble lives, scraping together enough money for a doctor's visit. It was people who wanted the convenience of being able to walk in and get physician care. And so it was really a strong lesson in that convenience is one of the most important drivers of the success of one of these programs. So I'll be happy to talk more about those things. I don't want to belabor them too long because I think the best part of the day is going to be question and answer. A little bit about New Physician as we stand today. We've always been a bit of a mystery to folks. Are we a technology company? Are we a services company? Well, we're 2 minutes in one. We're both. Our DMS product lines is how we help folks in the consulting space. In-place medical solutions is offshore and remote. We primarily have operations today in Brazil and Egypt. And then Medicine at Work is our domestic healthcare plan It's kind of a program for folks who want an on-site clinic, but typically are not thought of as being good candidates for on-site clinics, and I'll talk more about that. Medicine at Work uses a telemedicine model. We give folks a staffed on-site clinic into workplaces of 300 employees or more. They can choose from 3-day-a-week or 5-day-a-week staff services. There's a paramedic on site. The physicians come in through our classic model using video tools and using examination tools. We're a little bit different in the on-site clinic industry in that we don't have startup costs. We don't do long-term contracts. It's a pure per member per month compensation, which works very well for us. We give them convenience care, coughs, colds, flu, ear, nose, throat infections, skin conditions, all the usual things you would get from a convenience care or retail clinical site. In addition, kind of thinking about the needs of the employer market, we give them well-being programs, we give them health risk assessments, we give them biometric for their employees, biometric lab testing. We do blood pressure, cholesterol, blood sugar checks. All of our paramedics are NESTA certified for doing counseling, for stress management, weight management activities. And then we also give them lightweight OCMED support. We give them physicals, pre-employment physicals, job physicals, DOT drug screens. This is part of the services package. And then also DMS, because we've been doing this for a long time, we've had a lot of people like CVS Minute Clinics and Cleveland Clinic and other places come to us and say, you guys have been doing this as a service for a long time. We want to do it with our own nurses and doctors and clinics. We don't want to start from scratch. Can you tell us what to do and help us figure it out? And so we have a very healthy business line helping hospitals and health systems figure out how they want to do telehealth and telemedicine, what the tools should be. We help them with training. One of the, I think that's a differentiator for us in this market that's been recognized is that the trainers that we send out are not technology people. They are clinical people that have been doing it, in our programs just up to the day before. And then we help people with equipment procurement. We run some software for traffic management that we do. So that's about us and about New Physician. And they were asking me to go back to the main slide. And that's really what I wanted to show, Milton. I hope it covered some basics for us.
Okay, that's phenomenal. Thank you so much for that, President. I guess, can you, so, for example, from your work at Walmart and then the major failure of the health bot last year, I guess what's your prediction of something to telemedicine in this world, like from the Walmart, the CVS, the Walgreens? I know CVS has been doing this for a while, but I think the industry secret seems to be they actually loses money on their mini clinic and so on. Do you see a vision of a couple of years just you go to any of these pharmacies, there's a telemedicine clinic, or still like you don't see that deployment?
The economic viability of telemedicine has always been something that's hard to fight for. We've been fortunate by staying vested in per site revenue or per member revenue. That's been a secret of our success in terms of the almost 10-year run of New Physician now. I think as folks step closer to per encounter revenue, it becomes a different model. I think you're going to see development of models in pharmacies. I think in some parts of the country, there's still something about it that people don't believe that it works. I mean, the joke is that telemedicine is a 25-year overnight success story. I think those that have been in the field for a long time, we get a little jaded every spring or every January when somebody says 2017 is going to be the year for telemedicine. It's going to be the year telemedicine breaks out. And all of us have said, well, we've heard that every year, and there's always something that stops it. I think it has a lot to do with the fact that telemedicine is a tool that somehow captures the imagination of investors, it captures the imagination of the public, but then when it comes down to the nitty-gritty of actually providing the services and getting paid for the services, that's what some of the disconnects are. And I think that's still going to be a challenge as we go through the next couple of years.
Got it. That makes sense. I guess recently there's a Forbes article that says something as much as like 60% of employers are now offer telemedicine to the employees. And at the same time, I think the industry is like the actual utilization of the employees on telemedicine is actually extremely low in there as an industry. Like, do you see, why is that? Why is it something that seems to be pretty beneficial to the employees able to ask for telemedicine at the same time, so actual utilization is just so terrible?
There's a couple of things. We learned a lot when we started really aggressively getting into the marketing of medicine at work. And what we learned was that insurance companies and employers have wanted to have ways of modifying their employees' health behaviors for a long time. And if you look at everything from free gym memberships to online health risk assessments to online nutrition and counseling programs to Fitbits to pedometers and even now to telephone-based telemedicine, there's this magical 4 to 5% barrier of utilization. And so when you look at all these things as a bundle, that's about as far as they go. And the only time that you see utilization of a feature higher than that is when it's really strongly incentivized. We had one client of ours that, to start up the program, we did health risk assessments with physicians on every single employee. But to motivate the employees to get 100% compliance with that, or close to 100% compliance, they had to literally pay each employee $150 cash to do it. So you have to really strongly incentivize folks. So I think there's a natural resistance for people to not explore new things unless they're in a jam and they're of the type of character to try something new like that. And I think one of the things that works against it in some of these areas is that when you're hurting and you've got a problem, you don't necessarily think that that's a good time to try something new. You want to go with the tried and true and the proven. So the high uptake, I think, of 60% of employers offering telemedicine is, I think, just due to the promise that they make, that every patient seen by the telephone service is going to be one less patient in the emergency room. Yes, that can be a strong motivator if that's part of it. But then when you really look at how it's utilized, though, it's less strong. I think one of the more recent features in the press about it said, you know, the real, if you account for that low utilization of 4%, that $4 or $3 or $5 per member per month that gets paid for the telephone-based telemedicine equates to like $450 a visit. And so this is the way some of the new analysis is coming in. So I think that's kind of the landscape for that. And that's one of the reasons that as we take a look at our future successes in medicine at work, having it be a more affordable and more flexible approach to an on-site clinic is really the rationale for it, driving it, not so much the traditional healthcare behavior change. All of it.
Got it. That makes sense. Somebody do. I think like for like some of United Health, and they have these various actually payment mechanisms that help the people to get healthier. I mean, do you see also directly paying people to do this have a model? There's no way to get adoption.
Yeah, and I think it's one of the things that, you know, as a culture, you know, if we knew that our engines would be replaced in our cars for free, would we ever pay to change our oil? We tend not to be a culture of prevention, and that's one of the things also in the medical insurance space that's coming out now is that as folks are moving to high deductible health plans and health savings accounts, the numbers are starting to show that the patients are not using any of those savings or money or resources for preventative care, and they're deferring and eliminating doing preventative care and wellness visits, even though in some cases, you know, they get discounts for them. And so what they're doing, and the fear is that they're just driving themselves into more adverse and significant health events 2 to 3 years in the future. So it's there's a lot of psychology in the economics of the market, and I think the telemedicine can contribute and offers a lot of tools, but the market is the market, and it takes a little ingenuity to figure out the right way to apply it.
Got it. That makes sense. So, Glenn, one of the favorite thing you actually taught me that I'm very grateful for is the idea of like the telemedicine between the patients, the provider, and the payers. And the idea is, of course, is really benefit the patients, but the providers, they actually don't see that much benefit as a consequence of it. That create a lot of inertia from people to doing that. I was wondering if you could expand that a little bit.
One of the things that made the program at the Texas prisons work so well was, of course, is that that was an environment where there was an economic reason to care how frequently and how far somebody had to travel to see a specialist. That was it in a nutshell.
Mm-hmm.
We are in a public healthcare system where, as a rule, most folks don't really give a hoot how far patients need to travel to see their providers. And it's given rise to a very almost Byzantine Middle Ages approach to territories where hospitals and health systems have to build facilities, and surge centers, clinics. It's almost like building castles to get to the patients. Telemedicine, of course, can completely get around that, but there's a couple of things. It's been our impression for a number of years that telehealth and telemedicine benefits the patients. It certainly benefits the caregivers of folks involved with a patient who have to think about transportation and arrangements for folks who may be physically challenged. And in the end, it benefits the people who pay for the care. But you've always got to get past their fear of overutilization. The telemedicine makes it so easy. And it's one of the big fears of telemedicine parity laws, that if you're opening up a floodgate of claims and you're going to drain the coffers. But I think it is still pretty true that telehealth and telemedicine benefits patients and benefits the people who pay for patients. And providers are in a little bit of a pickle, and that is if they optimize their practice for face-to-face care, it tends not to leave them the time or the inclination to get involved in telehealth and telemedicine. I think that's one of the reasons that you'll see many successful business models on a scale basis where the doctors have non-distracted duties. They're not seeing a patient in their real clinic 1 minute and then seeing a telehealth patient the next minute. They're usually staffing and sitting down and putting themselves on for a 3-hour shift, 4-hour shift for telemedicine. Because telemedicine in the end is not a force multiplier of physicians. It will allow a provider to address a pocket of need that they otherwise would not have a good ability to address, but it does not allow one provider to do the work of 10.
Okay, makes sense. I really appreciate it. In fact, your perspective, I actually repeat this all the time. I thought it was one of the most insightful things you taught me. I really appreciate it. So we have some questions from the audience in there. One of the questions is, so from the provider staffing standpoint, what are the challenges have you seen, and what are some of the ways you have able to resolve?
I think in terms of provider staffing, we've been fortunate. We have a great group of core doctors. We kind of try to develop small group practices. And again, we stick to the concept of the non-distracted provider. One of the things that we do not do is the kind of the eHarmony of healthcare, where there's this, bulletin board of doctors waiting to take your call. Each of our clients has a primary doctor, a backup doctor, and each client will probably be seen by at most maybe 3 different physicians during their contracts. That's worked well for us. What's worked well for us is to have a way of providing the doctors that they feel comfortable that they're not wasting their time, that they're being compensated for taking the call. So there's an element of that compensation that's a flat hourly rate. And then we have some parameters for overutilization bonusing, that if they have more than X number of patients during a designated number of hours or days in a period, they get some supplemental support for that. So it's been a complicated mix. What works for us may not work for other people, but those are the approaches that work for us. Non-distracted providers, a base staffing rate for them. Of course, one of the nice things about telehealth and telemedicine and electronic medical records used in synergy is that you get a lot of natural performance documentation. You get a natural tracking of how long people are taking, who's moving too quickly on and off a patient, who's taking too long on and off a patient, who's documenting effectively, who's not documenting effectively. So the ability to audit and provide feedback to the care providers in a telemedicine business environment is actually better than in a typical clinic environment. So those are just some factors that helped us.
Nice, there, excellent. Okay, there's another question from the audience. So I guess so telemedicine seems to be like a perfect fit for things like the prison system, things like the public school, armed forces. Anytime you have these sort of captive, I guess, audience, things like senior living, all these things. I guess the question is from the audience is, what needs to happen until we actually see these more more consumer adoption to really get that going.
That's a good call. That was one of the jokes that we had when we were talking about our telemedicine programs in the prisons, is that, well, you have a captive audience, ha ha ha. Yeah, we had a captive checkbook. Because of the way the prison healthcare program was run, it was an all-in capitated operation, still is today. So many dollars per day come from the state, and with that, the managing universities have to pay for all inpatient care, all outpatient care, all medications, all dental work, all psych services, dialysis, autopsies and burials, hauling medical waste, running ambulances, everything. And so, again, while we got a lot of joking about it being a captive audience, it was a captive checkbook, meaning that for the first time we had a very clear economic model run on one checkbook ledger, for lack of a better phrase, where it was beautiful to be able to see the old water balloon analogy, where you press in on one side of the water balloon, where does it expand on the other side? As we were making investments in technology, as we were improving care access for specialty services, as we were reducing redundant visits, we were reducing redundant testing, we were increasing the velocity of care, the time to go from requesting a specialty visit to accomplishing a specialty visit dropped dramatically. All these things had real relevant evidence at a dollar level that was working and having positive effect. In fact, the whole system, which I think was around $35 million, was installed statewide across the state of Texas, 150 prisons over 250,000 square miles, without any supplemental funding requests from the state. Every time we needed to expand the system, we had generated enough savings from the first implementation to fund, and we were running wires, running Cat5 at that time, putting in servers, putting in computers, putting in printers, putting in scanners, putting in telemedicine gear, everything. It was all funded from the savings in the program. So I think part of your question goes to one of the challenges we have is the economic model. We have the luxury of a very clear economic model in the Texas environment, and to a certain extent in the Walmart model. It's really hard to find these days. Even trying to do a comparative cost per visit in public health care, by the time you deal with negotiated rates that the payer has, you deal with copays and deductibles, it becomes very difficult to show a dollar-for-dollar comparison of the value of the care. And that's one of the challenges, I think. I think depending on what happens with these new revisions and modifications to Obamacare, it'll be interesting to see whether or not we simply add more complexity to that or more simplification to that, because that'll give us a lot of clarity or lack of clarity about how telemedicine and its technologies can really create a better healthcare environment.
Got it. I appreciate that. I guess it really comes down to the money, the revenues, the engine behind there too. Okay, there's another question from the audience in there. How did you manage tort liability costs?
Yeah, we first of all, Texas has a tort limit for award. I think damage awards are limited to $250,000 or something like that. That was part of it, but that wasn't all of it, because we've expanded into other states since. We're operating in Pennsylvania, we're operating in Georgia, we're operating internationally. And when we first started, even when we were at the university, we were working outside the state of Texas, we had to buy insurance for outside the state. And what we found is that once the insurance group learned that we were doing this form of telemedicine that was site-based, that was, had some diagnostic assistance to it, and I think most importantly that we weren't doing procedures, we found that our rates were very manageable. In fact, they were so reasonable that I went back and made sure that they double-checked them. So they are, there's been a learning point for us, is that as a rule, we found that compared to medical malpractice liability insurance for clinical care, for an in-person clinic, it's much higher than for a telemedicine practice. Of course, it's going to depend a lot on the experience of the providers, but as a rule, we've found no challenges, and we've usually been pleasantly surprised when we get our rates and renewals every year.
Got it. Okay. So we got the two more audience questions. They're asking the same thing. And so I guess, did you have difficulty in terms of finding a physician to provide the service in terms of filling out the spots in there? And also, I guess something related to that, like, were you find difference between, like, let's say, finding some full-time basis versus things like some like locum base?
We've had a great experience with board-certified emergency physicians as our pool doctors. They tend to go in and staff an ER for X number of days, and then they like to use our services to fill in the off days. We have a couple of doctors that work for us full time, so we haven't found it to be particularly challenging. Most of our providers are like me, a little thick in the middle, a little thin on top. They're tired of buying comfortable shoes to run around the medical center, and the opportunity to see patients and exercise their clinical skills in this kind of modality, I think they find very satisfying. So at least for us as an operation, we've found it not too difficult to recruit physicians. I think one of the things that helps us there is that we have tended to focus on providers and provider groups that have reached a certain level of comfort in their professions. Even when we were at the university, we learned pretty quickly that to get the doctors to staff the telemedicine service, while we thought maybe getting a physician champion and going to the department chair would be the way to go, we found that to be not very satisfactory, because those folks tend to be focused on developing their own practices or their own departments. They wanted to make their money their own fashioned way. The more time they spent in the OR, the better off they did, etc. Where we found the greatest success was in the guys who used to be the department heads. That still had a lot of weight and credibility amongst the team, but had reached a certain comfortable level in their profession and in their careers, and were interested in looking at something new and something different, but had that weight of experience, had that weight of clinical experience that they were able to bring to the program. That's actually a question we get a lot. Are all our doctors young guys who can reset the device drivers and the software and understand all the technology? No. Actually, the vast majority of our doctors are over the age of 40.
Nice. Okay. Thanks for that really insight there. There's another audience question is, in terms of like the business model of paying telemedicine, do you find like just purely paying cash is better versus like going after the insurance route versus maybe subscription, or what would be the best mechanism with you like for actually paying for telemedicine?
Well, I'll share from our experience, and there's folks that are successful with other models, I'm sure, but for us, subscription revenue has been the way to go. It's an element of shared risk. They pay a certain floor, and then we challenge them to overutilize us, for lack of a better phrase. It probably has limited some of our sales growth in some markets, but it has enabled us to maintain a positive experience for our investors and for the business. Okay. I think there's an element that's fundamentally changing. I think when we were starting this game, you had significant capital cost to open the clinic. You were putting $40,000 to $60,000 into just the technology side alone at the clinic, and you had to overcome that. I think as innovative solutions have continued to come on the market, I think as you're seeing even cart solutions now dropping below $20,000, you're seeing other solutions being even lower than that when you get to tablet tools and things like that. I think that's going to be one element that enables more ability to survive on an encounter bill basis. But I spent 12 years running clinics, more than that actually, and healthcare is hard. You run your insurance receivables and they don't pay too fast. You run your patient receivables and they don't pay too fast. You spend a lot of time waiting for your money with encounter bill models, which is one of the challenges for hospitals and health systems every day. But it's a little bit of an added burden when you're trying to start a successful telemedicine business.
Got it. That makes sense. Okay, we've got another audience questions. So to what extent these state laws require the licenses, and there is a sort of like a limit in terms of adoption or practice? And also, of course, there are certain states, for example, like in the case of Texas, that requires sort of in-person encounter first before you could do telemedicine. Okay, do you see these sort of legal burdens as a hamper on telemedicine adoption, this is really not that big a deal.
Having played a role on the Department of Texas Health and Human Services Telemedicine Committee, and being a member of Texas's stakeholders panel for the board, medical board, for a number of years, I think there was a lot of misinterpretation about what Texas was trying to do in their rules. And in certain cases, I think a lot of it's going to be a moot point here pretty shortly. But we didn't find too much trouble with it because we stayed focused on the idea of an assisted examination, for better or for worse. And it had to do with our physicians being comfortable extending their license to the point of prescribing. Might have been due to our roots in academia or whatever, but the idea that I could give the providers a rich, high-fidelity experience with the patient by giving them some basic exam tools of a quality otoscope view, a quality pharynx view, a quality skin view with controlled lighting and focus, and the ability to auscultate using the stethoscope live under their instruction, under direct observation. These are things that I felt allowed our doctors to be like, people making pottery in a potter's wheel with all 10 fingers. And I always felt like as you took away those exam tools, or the clarity, and you went lower cost exam tools, you took away the number of hands they could lay on the clay. You're asking them to either make a choice of either continuing to script the way that they like to, but incur some risk because of things that they might not see, or the way that we found that they would naturally adjust for that, they would become more conservative in their decision making. And so I think that's a big part of this, as you take a look at the laws and the rules as they're being promulgated. When Texas did the clarification that first visits, the initial encounters can be done by video, that you needed, say, medical board and AMA guidelines of eye contact with the patient to establish the doctor-patient relationship. We've not found it to be onerous. We've also not found state licensing to be onerous. We tend to do it the old-fashioned way and either get a full license for our doctors in the state where the patient is, or take advantage of any telemedicine license tools that those states may offer. But I'd say we're in a different era today. I think there was a time that you would say, what are the biggest challenges facing telemedicine? And everyone would say, well, it's licensure and reimbursement. I think we're seeing that changing. I think there may be some corner cases where those are challenges, but I think well-structured and well-designed programs can succeed very well, and I don't think they're the big issues anymore.
Got it. I guess, as we're getting closer to wrap the session, I guess how do you see, with President Trump's, the various maybe changes from Affordable Care Act to various maybe changes, repeal, repair, all these things. Like, I know a lot of stuff is still in there, but do you have your personal prediction? How will be the new healthcare system coming there? How will that be some of the impact on the world of telemedicine?
Well, seeing that we don't know what anything looks like yet, that's hard to say. I do think there's a couple of things that have an opportunity to move forward the telemedicine marketplace. I think more states getting a telemedicine parity law in place is helpful, and I think at some point there will, and I think focus should be brought to bear, but I don't think we're going to have the opportunity because of the noise in the space. At some point, it will have to be evaluated, the rural HIPSA enablement of Medicare reimbursement for telehealth and telemedicine. That's going to have to be looked at and go by the wayside. So I can't tell you what it's going to be. I can tell you the two things that will help. And if in the melee and in the mix and in the crazy days of all the changes to come, if there's a couple of things that can be changed, I think parity is important. And I think dropping the rural requirement for Medicare is important because so many private payers drive their policies off of the Medicare requirements, Medicare policies. That if that rural space requirement were to go away, I think it would be a fundamental enabler for telemedicine businesses across the U.S.
Excellent. We heard it first with Glenn, and hopefully we can do even maybe spread the word and have some of these influence administration. I guess the final question, maybe as we're wrapping up, is like, so what are some of the big mistakes you see people making when they put together a telemedicine program?
Well, again, saying, our focus and our business strategies are all around site-to-site telehealth and telemedicine. And we're going to stay focused there because we think that's a good space to be in. And we know that it's a very divergent. Because a lot of times I'll give a talk and I'll talk about the fact that the telemedicine market today is a diverged model. You've got direct-to-consumer, smartphone-based video or audio, telephone call, telemedicine. And then you've got the site-based telemedicine, and that's really where we stay. As we take a look at that, some of the mistakes that we see a lot of folks make is telemedicine is really a place of service when you think about it. You've got hospital care, you've got outpatient care, you've got telemedicine care, site-based or otherwise. And if we tend to look at it that way, it will tend to succeed that way. What I mean by that is, if we look at the prison environment that we were in, one of the things that made it work was a decree from both the medical and administrative leaderships that every foray into specialty care, every referral, would go through a telemedicine consult first before they actually move the patient. Obviously, with the emergency cases, that didn't happen. But any standard escalation from primary care went to telemedicine. It wasn't conditional. And we see a lot of folks to this day that say, well, Glenn, give me the secret. What is the best, where should you start? It's dermatology, isn't it? We really need to start with dermatology. And the answer is no. There's really no best way to start other than the fact that you don't pick one winner. What worked for us was the idea that if you're going to get into the game, you've got to go deep. And one of the things that we tell folks is have your first project be more than one discipline at more than one location. So you want to bring up at least 2 disciplines at 2 locations to really get going. And you got to have some guts to live with the blowback that's going to happen in the first half a year during the program's implementation. Because that was one of the things that worked in both our environments. The analogy is this. There's been a long legacy of telemedicine as not being successful. I mean, again, telemedicine is a 25-year overnight success story. I'm not sure that there's a single hospital or health system in most states that has not tried dabbling in telehealth or telemedicine in some fashion over the last 20 years. They either got a grant or were given grant money, had somebody from a major university come to them with grant money. When we were starting our programs across Texas, there was a lot of legacy equipment sitting around. It was like I felt like we were in one of these movies where people are uncovering evidence of a lost civilization. We'd be out at a mental rehabilitation center somewhere in Texas, and we'd say, hi, we're the telemedicine people. And they would go, oh, telemedicine. We used to have telemedicine. And they would lead us through the building and lead us back to this conference room and throw open a closet in the conference room. And sitting there was untouched, pristine, brand new setup, but probably never fired up except for press demonstrations, a beautiful telemedicine system from 7 years ago. And it was like the evidence of a lost civilization. And it has a lot to do with the idea that you need to have a great business model first. You have to apply it across a number of disciplines and a number of locations together. Otherwise, it would be the equivalent of saying, we're going to try building an ambulatory surgical center in this new town. And we're going to build it, and we're going to staff it. We're going to have it only open on Tuesday mornings for left-handed people. We're going to run a few patients, and then we'll see how well it works. And then you run the evaluation, and you say, but the cost per patient is so high. There's a lot of analogies to that, a ridiculous analogy to a lot of telemedicine pilot programs. They go in, they see a few patients, they try to run some numbers, and the numbers are relatively meaningless because it never reaches a critical scale. If there's one thing that we have focused on in our programs, it's always looking for starting off with a plan to scale right away and going in deep. And we've been successful in some markets and not successful in others. But where we have been successful, it has always pointed back to the fact that we didn't just pick one location, try it on a couple patients, and then try to extrapolate from there. You have to step in with some authority.
Got it. Thank you so much for the insight in there. By the way, for the audience, I apologize we're not able to get to everyone's questions in there. I would like to maybe again huge thanks to Glenn, and also for the people who's interesting in this continued topic, I invite all of you to come to our next week's webinar. So next week, we're going to have one of the phenomenal, maybe the world expert on the specific in the case of taxes, the laws, there's various things, the details, subtlety in there, which I think may have a big impact in terms of general telehealth overall. Again, thank you so much, Glenn, for your wisdom and insight.
Great. It was great to be here, Milton. Always great to see you and be part of your programs. Always wishing you a lot of success in your business, as I know you wish me and mine. If there's other questions that we didn't get to, I'll be happy to respond to them offline. And I believe we're going to make my slide deck available as a PDF through your website.
That's correct. So again, this session will be recorded and put online, and people can watch it afterwards. And thank you so much, Glenn.
Hey, take care, everybody. Thanks so much for your attention.